You will know hemochromatosis for good after this lesson. Let's do this. We'll do an overview, jump to the presentation with signs and symptoms, then a diagnosis, followed by complications, and finish with management and treatment. Overview. First off, you heard hemochromatosis in our medical terminology and lingo series. We asked you to break this word down. Let's do it now. Hemochromatosis. Hemo means blood. Chromato means color, and osis means condition. This is an iron storage disorder that causes changes of color in the blood. But not only the blood, but also the organs and tissues of the body. Hemochromatosis is characterized by an excessive iron absorption in the intestine, which leads to iron deposited in organs and tissues. It's an iron overload, too much iron. The human hemochromatosis protein, which we abbreviate to HFE, the primary type of hereditary hemochromatosis is inherited autosomal recessive. The C282Y mutation is the most common mutation in the HFE gene on chromosome 6, which causes most cases of hereditary hemochromatosis, but other genes can cause this mutation as well. Secondary types of hemochromatosis are non-genetic and can be from multiple blood transfusions, chronic hemolytic anemias, and rare but even excessive iron intake. HFE gene is important in regulating the iron metabolism and iron absorption from food, because most of the iron in the food is absorbed by enterocytes in the gut and passed into the bloodstream, and this is why it causes an iron storage disorder and overload. So to explore all of this, we'll dive into iron physiology. But before that, we can't do these videos without you. If you hit the subscribe button, we'll make sure to do a lot more of these helpful lessons. Normal iron content in the body is about 60 to 170 micrograms per deciliter, and it exists in four main forms. First form is a storage form. We have ferritin and hemochromatosis. Second form is transport. Iron is bound to transferrin, which is for the transportation of iron in the plasma. Third form, you can find iron with hemoglobin, which is where the majority is found. And hemoglobin is key because it carries our oxygen around. The fourth form of iron can be found in other proteins and enzymes across the body. Iron is usually consumed from a variety of food and vegetables, and after eating it, it goes into our stomach to get absorbed into the duodenum. At the duodenum, iron is absorbed through a transporter at the apical surface of the enterocytes called DMT1. From here, iron gets stored up as ferritin, or it can be reabsorbed into the blood via the transporter Ferroportin. Through the Ferroportin transporter, iron is bound to the transporter, which we called transferrin. This is in the circulation. From here, the transporter takes the iron over to the rest of the body. We'll see transferrin taking the iron into the bone marrow, where we can make more red blood cells through the process of erythropoiesis. Iron stimulates and influences this process, and boom, we have new red blood cells into the circulation. And then eventually, after 120 days, the older RBCs die through the spleen, particularly by the way of the reticuloendothelial system, so you see this recycling process take place. Iron now gets released back into circulation, gets bound to transferrin, and yes, we must importantly note that the majority of iron, about 75%, we take in goes to erythropoiesis because our body needs new red blood cells. And the rest of the iron that doesn't do this goes into organs, and specifically the liver, where the liver stores the iron as ferritin, about 20%. Here the liver stores this key protein, hepcidin. And hepcidin you can label as the main regulator for iron absorption, regulation, and metabolism. It's iron's big brother. Its goal is to lower serum iron and make sure it's not acting up. Hepcidin gets stimulated and released when there's a lot of iron in storage. And you'll also find inflammation can promote the release of hepcidin as well. So hepcidin does a variety of different things to stop little bro iron and lower the serum iron. A main way of it bossing iron around is inhibiting ferroportin, the transporter we discussed. It essentially promotes the destruction of ferroportin both in the enterocytes and the liver, and even in the red blood cells. Ferroportin is the car keys to drive into the bloodstream and jump into its car, the transferrin. So older bro just takes the keys away. So hepcidin inhibits the release of iron into circulation. Iron can't hop on the highway of blood throughout the body, and so we get lower serum iron levels. So in hemochromatosis, we are taking high levels of iron, and yes, you can overdo the intake of iron in your diet, but it's unlikely. What we do see is hereditary mutations in the transporter Ferroportin. And here, sometimes there's excessive Ferroportin, meaning with so many Ferroportin transporters, a whole lot of iron can get into the circulation. We're mostly concerned in this lesson with what we discussed earlier, which is the chromosome 6 HFE gene mutation. Actually, this mutation is also known to reduce hepcidin. And guess what? If you mess with big bro hepcidin, little bro iron has no one to take its keys. No inhibition of ferroportin. So you have ferroportin activated and releasing all of this iron into circulation, causing what? An iron overload. Other causes of hemochromatosis include any sort of liver disease, sometimes from alcohol or non-alcoholic fatty liver disease, and this again shuts down hepcidin. And so ferroportin gets a free ticket to release iron. Another cause of hemochromatosis, which is really a secondary hemochromatosis, includes thalassemia major and sideroblastic anemia. For this phenomena, just think of the anemia stimulating the regular erythropoiesis, but what you actually get is ineffective erythropoiesis, which leads to a suppression of hepcidin. So now think about it. You have all of this iron in circulation. The transferrin transporters become saturated, used up. And now iron says, hey, let's go bind to other stuff such as albumin, citrate, and acetate. This iron is referred to as non-transferrin bound iron. And guess what? Cells throughout the body will take up this non-transferrin bound iron. And this is what you'll see as we explore the presentation of hemochromatosis and explain the signs and symptoms. It's initially asymptomatic because it takes some time for enough iron to build up in the body for it to become symptomatic. So it presents in men around the age of 50, and for women it presents later because of the elimination of iron through menstruation. Just think, eliminating the iron periodically, it's going to take longer for the iron stores to build up. Symptoms appear 10 to 20 years after menopause. So let's take a look at our guy. You may know him. He's got a red hoodie on to remind us this is a heme condition to do with the blood and iron. He's got this afro pick in his hair, which tells us that the most common mutation for hemochromatosis is a C282Y mutation in the HFE gene on chromosome 6. He has baggy eyes, showing a typical symptom of chronic tiredness and fatigue. Here we show the knee because there's arthralgia, pain from the iron deposits in the joints. We'll see bronze discoloration, also known as bronze diabetes, and this pigmentation is from the iron deposits in the skin. Presentation can show hair loss. And remember, while we discuss these areas, hemochromatosis is when there's an excessive iron absorption in the intestine, leading to iron deposited in organs and tissues. So we find sexual problems such as erectile dysfunction and amenorrhea. Presentations include cognitive issues such as memory and mood disturbance. Patients have cardiac arrhythmias, abdominal pain, and altered glucose hemostasis. Think hyper or hypoglycemia. So how do we make a diagnosis of hemochromatosis? The main diagnostic method is to perform a serum ferritin level. Ferritin is a type of iron in the blood. It's important to note ferritin is an acute phase reactant, which means it increases in inflammatory conditions in the body. So this does make ferritin unreliable because it can be high for other reasons and not for hemochromatosis. We can perform a transferrin saturation, which helps distinguish between high ferritin from iron overload, which means there's high transferrin saturation, from high ferritin caused by other causes, such as inflammation or non-alcoholic fatty liver disease, which in this case, the transferrin will be low or normal. If serum ferritin and transferrin saturation are both high, this indicates iron overload, and there's no other explanation for these results. We do genetic testing to confirm the diagnosis of hemochromatosis. Well, back in the day, the gold standard for diagnosis was a liver biopsy by doing a Perl stain, which was to identify the iron concentration in the parenchymal cells of the liver, brown spots inside hepatocytes. It becomes blue with Prussian blue stain. But ever since genetic testing, this method is now outdated. An abdominal CT scan may be used to show nonspecific increased attenuation of the liver. That may alarm us and suggest iron overload in the liver tissue. And we can use an MRI scan to see more detailed imaging of the liver deposits of iron. And an MRI can also be used to see iron deposits in the heart, which we see in complications of hemochromatosis. For complications, just think of deposition of iron in tissues. Like we said, iron has effects throughout the body. Because of the non-transferrin bound iron gets taken up by cells throughout the circulation. You can expect the liver, pancreas, heart, pituitary glands, joints, and as well as the gonads. Again, looking at our guy, here in the liver it receives excess iron. The intestinal mucosa absorbs excess amounts of dietary iron, which is received passively by the liver. It causes typical issues of liver disease, including liver damage and cirrhosis. And the cirrhosis can lead to hepatocellular carcinoma, cancer in the liver. In the heart, these iron deposits can cause restricted or dilated cardiomyopathy and arrhythmia, which can affect the functioning of the heart. And yes, it can even lead to heart failure. And don't forget, in the pancreas, the iron deposits can cause altered endocrine and exocrine function, leading to type 1 diabetes. In the joints, actually, iron overload can lead to chondrocalcinosis, which is calcium deposits in the joints, and this leads to arthritis. Iron depositing in the pituitary can cause secondary hypothyroidism, preventing the thyroid to produce the necessary amounts of hormones. And it can lead to secondary hypogonadism, which is when the gonads don't produce testosterone or estrogen. Well, in the gonads, you have to note that the iron deposited in the pituitary gland and the gonads causes endocrine and sexual complications. So testicular atrophy is seen over here. It can cause impotence, amenorrhea, where the period stops in women, and of course, infertility. And finally, the skin. We have one of the most early signs of hemochromatosis, which is the bronzing of the skin due to melanin deposition and iron. The high yield point here, which is your key takeaway, note the triad of complications: cirrhosis, diabetes, and the bronzing of the skin. This should scream to you of hemochromatosis. Lastly, let's see management and treatment. And the key to managing hemochromatosis is getting rid of excess iron in the body. We can do this by phlebotomy venesection, which is weekly or bi-weekly protocol of removing blood from the body so extra iron is gone. Really up until ferritin level is less than 50 and the transferrin saturation is less than 50%. It's followed by lifelong maintenance phlebotomies every 2 to 4 months once excess iron stores are removed. Chelation therapy may be used in a small number of cases where regular phlebotomies are not possible because it's difficult to remove blood regularly. Think very thin or fragile veins. Medications to note are deferoxamine. Chelating agent binds iron molecules leading to deferoxamine excreted by kidneys, and through urine excretion, it decreases the iron load. Okay, lastly, here's a question to send you off. Which is the most common cause of death in treated patients of hemochromatosis? A. CHF, B. Hepatoma, C. Infection, or D. None of the above? Drop your answer in the comments below. If you'd like to see more of this lesson, head over to our Instagram page and TikTok channel at rev.med. We'll have this lesson along with many other topics for you to study. By the way, don't forget to do questions. Are you learning something from our videos? Well then click the subscribe button to your right. We are releasing high-yield lessons and ways for you to get ahead in class. Be sure to follow us on Instagram to take interactive quizzes and view your favorite diagrams. Nothing can stop you, but only if you believe in yourself. You got this.